Hey guys, my name's Steven. Today we're going to be discussing musculoskeletal ultrasound, so let's get started. I think overall MSK ultrasound is a really useful modality in the ER, and that's because X-ray and CT aren't great at diagnosing tendon or ligament injuries. So ultrasound is a really good alternative when MRI is unavailable or impractical. However, I think many ER docs are really hesitant to use ultrasound for MSK issues, and that's just because lack of training and familiarity. So I'm here to tell you that MSK ultrasound is actually something that's really easy, and I think after today you'll be out there scanning some knees and Achilles tendons with no problem. So first things first is probe selection. I generally use the curvilinear probe and the linear probe for MSK. So let's discuss curvilinear first. The curvilinear probe I really use for larger joints, and I start out to kind of survey the area. I use this to identify landmarks and note any obvious abnormalities such as joint effusions or like when looking for things like a shoulder dislocation. It's hard to get the linear probe in position to really see two bones across a joint space, so that's where the curvilinear probe is really useful. Now, a key thing when you're doing MSK ultrasound is to review your anatomy before you scan. So let's take the knee, for example. If we're talking about a potential, let's say, patellar tendon rupture, the first thing we want to do is identify the patellar tendon and what it should connect to. So here we have the patella, and the tendon runs down to that tibial tuberosity here, and the quadriceps tendon is up here. So if we know that we should be looking for a bony structure with a tendinous structure attached to another bone, it's a lot easier to kind of decide what we're seeing on ultrasound, because MSK can be a little confusing when you first get started. The other good thing to note is structures like bursa and fat pads, where they are. And so when you see them on ultrasound, you're not concerned that there's some pathology. The last thing is that if you ever notice something like a fluid collection that you're concerned about, just compare it to the other side, and that will tell you whether or not it's pathologic. So using the knee as an example, here we have the patella up here. You see that hyperechoic line with black shadowing behind it. And then you see this tendon right here connecting to another bone, and that's the tibial tuberosity there with shadowing behind it. Remember that the indicator is usually pointed towards the patient's head or towards the patient's right. So in this scan, the indicator is towards the patient's head. So you see patella here and tibial plateau there. Now, like we said before, this is the curvilinear probe. See that curvilinear footprint? We don't really see the tendon super well. So we are going to switch over to the linear probe so that we can really identify all the fibers of that tendon and see if it's disrupted. So here's a shot of that patellar tendon with the linear probe, and you can see just how clear and easy it is to identify. So here's the patella. You see that shadowing behind it. And then here's the anterior tendon sheath. Here's the posterior tendon sheath. And you see those nice organized fibers of the patellar tendon running all the way down to the tibia as I kind of fan down later on in the image. Now, when we look at the image here, so this is the anatomy next to it in case you were at all confused. You see patella and the tendon very clearly. So this is just one example, and I think, like I said, the key is looking at that anatomy before you go and do the scan so you know exactly what you're looking for. Now let's talk about the elbow. So on the elbow, say you have a patient that's got a little bit of pain at the radial head, and you're concerned that maybe there's an isolated radial head fracture, and what would you normally see on an ultrasound for that? If it's an adult, you'd probably see like a posterior sail sign, and what that represents is a fluid collection or a hematoma here posterior to the humerus that's kind of displacing that posterior fat pad up. So fortunately for us on ultrasound, that's really easy to identify. So we look over at the anatomy here. We have the triceps, we have the olecranon here, and we have the humerus. So with the ultrasound, we see the olecranon there at the beginning, tricep muscle here, and tendon coming down and attaching here. And what is this we notice here? We see that big anechoic area that actually represents this little accumulation of blood within the joint, which would be like a posterior sail sign on an X-ray. And notice you have another hyperechoic line with shadowing there, and that's the inferior portion of the humerus. So as you can see, as long as you know the anatomy and kind of know what you're looking for, MSK ultrasound is really easy. Let's go over that last concept that we discussed earlier, which is evaluating both sides in the setting of a suspected Achilles tendon rupture. So here's that Achilles tendon, right? So these images are the same and these images are the same. Now, if you were to just look at this in isolation over the Achilles tendon, you might not think that it looked like anything abnormal. However, when you compare it to the normal side, you see how organized this tendon is right here. And this is a normal Achilles tendon. And here you see it looks very disorganized, and there's little pockets of anechoic material in there, and you don't have that organized tendon structure. So whenever you're looking at an injured side, Go ahead and fan through the area that the patient's complaining about pain or where you think you would expect to see pathology, and then compare that to the other side. And if you notice any abnormalities, then you should suspect that there's an injury there. So that's basically it. MSK ultrasound's fairly easy in my opinion. Remember to compare to both sides like we just discussed, know your anatomy before you do the scan, and usually start with the curvilinear and then go to the linear probe afterwards. Thanks.